Hello, everyone, and welcome to the Strength and Hormones podcast. Today is another LOdown episode, a solo episode where we'll be diving into why blood sugar and A1C increase in perimenopause and through menopause and after menopause, once you've gone through that menopausal transition. This is something that we see so often clinically in practice. And a lot of people don't know that there's so much that can be done to actually offset some of these changes. And we're going to talk about how some of these changes are actually natural. They are natural physiological things that occur, just like when you're in your younger years during pregnancy, your blood sugar changes as you move through each trimester to help with growth and different processes. Something very similar happens once those hormones start to drop off in the perimenopausal and menopausal years. And so we're going to talk about what to know about this, what you can start on early if you still are in the perimenopausal years. And then if you are already in menopause, what you can do to help support your body and help prevent this becoming something more serious like type 2 diabetes, or even just the everyday complications of high blood sugar, like increased thirst and difficulty losing weight, fatigue, sugar cravings, so on and so forth. So let's get into today's episode. I want to first start off by talking about some of the reasons why we care about this subject. We are learning more and more every day about the role of blood sugar in pretty much every chronic disease. We know that there's a link between dysregulated blood sugar and diseases like cardiovascular disease, heart disease, and cardiovascular complications. There's, of course, a link between high blood sugar and diabetes. But we also know that there's a link between mental health disorders like depression and anxiety, as well as dementia and Alzheimer's disease. Alzheimer's is now being called type 3 diabetes because of the glucose dysregulation that occurs where the brain essentially gets starved of energy because the brain becomes insulin resistant. The list goes on. And in terms of how blood sugar is connected to so many chronic diseases. And as we get older, the body is more susceptible to chronic diseases, right? Our body there's been more oxidative stress that's going on. Our cells are aging, getting older. And so we need to be thinking about ways that we can prevent those from happening. And one of the best things that we can do is really support our blood sugar to help with prevention of these more serious complications. One of the things that oftentimes isn't tested when you get blood work done is a hormone called insulin. And if you've been listening to my podcast, you follow me on social, I talk about insulin a lot because it's this hormone that really sits at the cornerstone to regulating so many of our other hormones, like our thyroid hormones and our sex hormones, especially androgenic hormones like testosterone and DHEA and some of these others that are implicated in a lot of women's health symptoms and conditions. But this is something that we see actually start to elevate about 8 to 10 years before we start to see issues present with both fasting blood glucose as well as postprandial. So that would be like 1 or 2 hours after eating a meal, as well as your A1C. Now, just in review, a hemoglobin A1C, or A1C as we often call it, is what we call a 3-month rolling average of blood sugar. It's oftentimes only tested by itself. Sometimes it's not even tested with fasting blood glucose, but there are limitations to it. It is a really great measure to tell us what's going on with your blood sugar, but some people's red blood cell turnover is slower, and this could actually cause your A1C to be higher. And so we always want to be looking at A1C alongside of other metrics of blood sugar control and alongside your CBC, so we can see red blood cell markers and things of that sort that help us understand, could you maybe have an abnormal red blood cell turnover that's causing this elevated A1C, or is this something that really is a blood sugar problem? We know that the lowest risk for any of these blood sugar related chronic diseases is an A1C at or below 5.2. And generally, it's not going to flag as prediabetes until you get into the 5.4 to 5.5 range. And then generally might not be something that's even treated until you're well above that, into the 5.7 or above range. But insulin actually elevates about 8 to 10 years before A1C elevates and before fasting blood glucose elevates. And so there's something that we call the insulin resistance curve. And this is essentially an adaptive process that happens in the body. So there's 2 phases to it. In phase 1, we see that there's what we call insulin resistance. And so your insulin levels are going to increase. and it's helping to be able to bring your blood sugar levels into the normal range. So generally your A1C is going to look pretty normal. Your fasting blood glucose is going to look normal. Oftentimes insulin isn't even tested, but if we did test it, we would see that insulin is high. It's above the optimal range, which functionally we consider between 3 to 6. When this is happening, this can go on for many, many years. And essentially what's happening is that the pancreas is overcompensating. There's a lot of blood sugar dysregulation happening, but the body is finding a way to adapt to it, right? By increasing the output of this hormone insulin to make sure that all that sugar that's in the bloodstream is getting into the cells that can get it out of the bloodstream. And so this will go on for many, many years. And then about maybe 10, 15 years after that, that's when you'll start to see that blood sugar and A1C increase and insulin actually drops. And now you have really low insulin levels. So if we were to test your insulin, it might even be at 2, it might be at 4. And that's because the pancreas has essentially burned out. The beta cells that are in your pancreas are tired. They've been overworking for many years. And now you have none of the hormonal way to offset and help get that blood sugar out of the bloodstream. And so now you see A1C increases and fasting blood glucose increases. And at that point, that's what we call diabetes. And at that point, it's much harder for us to reverse the insulin resistance. It's not impossible. I've seen it done many, many times in my career, but it is more challenging because the beta cells are burnt out, if you will. And this is an adaptive process. A lot of things in the body work like this. Same thing with a lot of our other hormones, like your adrenal hormones. You've probably heard of like adrenal fatigue phase 1 and phase 2, where the same thing happens. The adrenals overwork. You're making a lot of cortisol and the body says, I'm tired. And then now there's no cortisol production that happens. Same thing happens. So it's a very similar response that we see in both of these situations. Now, going into some of the other hormonal effects that cause this, during perimenopause, what we see is that estrogen has this pulsatile fashion. So estrogen is like pulsating all throughout the month, and progesterone tends to be pretty low. Whereas when you're in your reproductive years, we see a very nice kind of flip-flop fashion happen. When you're in the first half of your cycle, estrogen is peaking around ovulation, progesterone's pretty minimal. Then once you ovulate, progesterone production comes up. You've got a really nice progesterone peak. Estrogen's still there, but it drops off quite a bit. In perimenopause, there's not these like big round curves happening. Instead, we have these like constant highs and lows of estrogen all throughout the cycle. And then we have very low levels of progesterone. And that's what often causes a lot of the perimenopausal symptoms. It can cause difficulty sleeping, anxiety, spotting, bleeding throughout the month, really short periods, and ovulatory cycles. So if you are trying to conceive at that point in your life, there's probably going to be difficulties because we're not getting adequate levels of progesterone. And then menopause is essentially just defined as no menstrual cycle for 1 year. So you haven't had a cycle at all. And generally that'll take a couple years for that to happen, right? And if you've been through menopause, you probably know the last couple years, it was like your cycles were getting further and further apart. And then eventually you didn't have a cycle for a year. And at that point, we can actually look at some lab markers like FSH and LH, and we'll see that those are really high and that your estrogen and progesterone levels are really low. Well, estrogen was really helpful for helping with your blood sugar. When you were younger, estrogen was helping to be able to support your blood vessels, to help deliver insulin to your muscles. Remember, insulin is that hormone that gets blood sugar out of our bloodstream. It was helping lower blood sugar. And we really consider estrogen to be like an anti-diabetic hormone. It helps to prevent and protect against type 2 diabetes. And so once those estrogen levels drop off completely in menopause, we start to see issues develop even further with your blood sugar because you don't have that estrogen on board to help with that glucose metabolism and to help with the blood sugar, lowering of the blood sugar. And this has actually been reported by researchers. They actually looked at a couple of different situations and they really identified that the effects of estrogen on glucose or blood sugar are mediated or they're controlled through 4 different ways. The first one is through protecting and also facilitating the secretion, so the release of that hormone insulin, and helping control glucose deliverability to the tissues of the body that need it. So essentially getting carbohydrate and sugar out of the bloodstream and into places like our muscle and our liver. The second one is through actually changing the way that we burn energy. So when you're in your reproductive years, women tend to burn more fat for energy than men do in particular. But when estrogen levels drop, you tend to burn more carbohydrate. And so estrogen actually helps with energy burning and burning lipid or fat as the main energy source. The third way is that estrogen helps work as an antioxidant. So when we don't have that estrogen there, we're more prone to a pro-oxidative or more of like an inflammatory state. I talk a lot about the role of this as it relates to the thyroid in particular in our podcast, our last LOdown episode on glutathione and the thyroid. So go back and listen to that if you want to learn more. And then the fourth way is actually through just the whole body, like central effects that estrogen has on metabolism. So you can see the profound effects that not only does estrogen have on just blood sugar in general, but also just overall metabolism of how we're burning food for energy when there are really low estrogen levels. And I touched on this a little bit for those of you that aren't in menopause in my PCOS versus amenorrhea LOdown episode, because this applies not just to menopause, this applies to any low estrogen state for a chronic period of time. So we can see this happen in women who aren't having a period, for example, or, anytime that there's a low estrogen state. But we see this really exacerbate in menopause because it's a very low estrogen state for a great period of time. Progesterone, on the other hand, if you're wondering, doesn't really help with blood sugar. Progesterone actually can make blood sugar more erratic. So it's not anti-diabetic like estrogen is. It's estrogen that really is the sex hormone that's playing the biggest role here on blood sugar control. Now, the third hormonal way that blood sugar gets impacted is through thyroid hormones. Thyroid diseases are most common in women, but they are even more common in women postmenopausally. It's been estimated that up to 20% of women that are over the age of 60 have an underactive thyroid or have hypothyroidism. 12 to 20%. So that's a pretty good chunk of the population. And we see that as women get older, more problems present with thyroid dysregulation. And thyroid hormones play a really important role in regulating our blood sugar. They help with glucose metabolism, so metabolizing sugar, kind of similar to how estrogen does. And when we don't have enough progesterone because we're no longer cycling, this can even happen in perimenopause, right? Because I mentioned that typically also creates a low progesterone state, that this can actually disrupt the effectiveness of thyroid hormone production. So I always mention that progesterone is pro-thyroid and our thyroid is pro-progesterone. When we don't have adequate levels of progesterone, we tend to see more complications with the thyroid arise because when there's not enough progesterone, the effectiveness of the thyroid gland is diminished. And we see, because of that, we see less thyroid hormones being made. So now we've got two different hormones that are affecting glucose metabolism, right? You've got your three really, estrogen, you've got your progesterone that are both low, that are impacting it in different ways, and then your thyroid hormones that are impacting things. And then the last reason that we see these blood sugar changes really occur is because of the natural drop in lean muscle mass that occurs. Really, every year after 30, you're losing muscle mass. It's estimated that you lose about 3 to 8% every decade. So every 10 years after the age of 30, which is really scary to think about, right? So when you think about, okay, where are you when you are postmenopausal? We've probably had a great deal of muscle mass loss occur. And muscle, I've talked about this so much in the past because I'm such a huge fan of muscle as our biggest metabolic weapon, because muscle disposes of about 80% of all glucose. We have a term that is kind of been newly defined as like muscle insulin resistance, where it's essentially that your muscle is resistant to glucose getting in, and our muscle is the primary place that glucose gets taken by that hormone insulin. The other places are places like our liver and our brain, but in much smaller quantities. So the more muscle we lose, the less we have to help us regulate blood sugar. I like to think of muscle as like a sponge to sugar. So it's helping to be able to constantly dispose of carbohydrate when we consume it, and really just regulating our overall resting state of our blood sugar levels. So if we're not building muscle as we're getting older, or we're not trying to sustain our muscle as we're getting older, then we're constantly getting into a greater deficit of muscle, which is going to increase issues with blood sugar happening. So I know I gave a lot of different reasons as to why these changes happen, more so just to show you that they are natural physiological changes that occur. And I don't share these with you to doom you that there's nothing you can do about it. I share them with you to empower you to understand your body more, because I truly believe that the more that we understand the natural changes that are happening in our body, the more that we can work with our body rather than against it. And the more that we can say, oh, I understand, my estrogen's dropping, my progesterone's dropping. What can I do to support these hormones or offset those changes that are happening so that I don't end up in that position where 10, 15 years down the road, now I have high A1C and possibly diabetes developing. So the first thing we can do is we can work with the hormonal changes. We can say, okay, I know that this is my natural physiological change that's occurring. That means I need to change the way that I'm possibly eating to really be more supportive of blood sugar. Maybe you can't eat the same load of carbohydrates or in the same manner that you did when you were menstruating and you had that high estrogen on board to help with blood sugar control. Or if you choose that you want to do bioidentical hormone replacement therapy, then maybe that's where you look at using estrogen and progesterone support to be able to help with some of the blood sugar management that starts to get dysregulated. So you see, we can kind of decide, do we want to go the natural route and not use hormone replacement therapy and just say, okay, these are the changes I know are happening. How can I offset these? Or do we want to look at having some support in place, hopefully still making some nutrition changes, right? Because just having hormone replacement therapy doesn't fix everything. Hormone replacement therapy generally is bioidentical, but bioidentical hormones don't necessarily work 100% of the way our natural hormones do. They're never as good as the natural ones. So we still need to be mindful of these things, but it maybe gives you a little bit more wiggle room in these areas. Plus, there's other benefits potentially of bioidentical hormone replacement therapy for some women that are experiencing certain menopausal symptoms. I've got another podcast episode on that, on bioidentical hormone replacement therapy, if you want to learn more about that. I also have another episode on nutritional changes in your 40s. This episode really should be like 40s and beyond, because I talk about a lot of these natural changes that are happening and how we can modify our nutrition to actually work with these natural changes. So that would be a good follow-up episode to learn a little bit more about this as well. And this is one of the reasons why we don't recommend the same approach for women in their peri and postmenopausal years as we do for women in their reproductive years. I would never recommend the same thing because the body is different hormonally. And so it's not the same environment of how we should eat, how we should exercise. There's different changes that need to be made. And if we can, again, work with those changes, we can get the same outcomes. A lot of women, come to us and are like, well, I'm in a postmenopausal, I'm not going to be able to see these changes happen. Are you still going to be able to help me? Yes, we just have to understand this is the state the body is in. How can we work with it, right? And that's really what we're trying to parallel, is what's naturally happening in your body. Another thing that we can do is build lean muscle mass. It's never too late to start, but the sooner you start, the better. We always want to be thinking about how we can be building and sustaining our muscle. Not only does it help support our bone mineral density as you get older and those estrogen levels drop, but it helps support your blood sugar. It helps prevent sarcopenia, age-related muscle loss that can make you frail and things. And so that's one of the reasons why we created our Strength and Hormones workout program, was to guide you exactly through how to do that, what those workouts look like to build and sustain lean muscle mass without overtaxing your nervous system and creating more problems, because we can definitely do that if we do too much of a good thing. But we can also eat and supplement to support our lean muscle mass. There's really effective approaches in terms of how we time certain nutrients, how we eat protein throughout the day. We also know that as we get older, there's been tons of research in supplemental use of things like creatine monohydrate, especially in the older population, for helping prevent things like age-related muscle loss and sarcopenia. So those are approaches that we can take if we see that muscle loss is declining. I also always recommend that if you haven't already, try to get a DEXA scan at some point once you go through menopause. If you can get one before, so you have a baseline, that's great. And then get one once you go through menopause, that's even better, so that you have a comparison. A DEXA scan not only is going to tell you your body fat percentage, but it's also going to tell you your bone mineral density in different areas of your body, like your hip, your back, your femur, that are really important to understanding, if we need to be on mineral supplementation, or how you should be working out, and how much resistance training you should be doing to try to make more deposits into the bone. But if we can get ahead of it before your estrogen drops off, we can see much greater improvements happen, because once that estrogen drops off, it is really hard to build new bone. But when you have that estrogen on board, it is much easier for us to do so. There's even been research that's shown that calcium supplementation, once estrogen is low, doesn't do anything. It doesn't preserve your bone. It doesn't build new bone. It's kind of a waste, honestly. And so we really want to be making those mineral deposits with adequate minerals in our diet before estrogen drops off, so that we can get all those deposits. And so going back to creatine can be a great way to help support our lean muscle mass, and a DEXA scan would give you that information about not just bone mineral density, but also lean muscle mass, fat mass, so that you can see how much muscle has been lost since you've gone through menopause. And then you can set goals for how to rebuild that. It's not impossible for you to build muscle once you've gone through menopause. We just might have to take more strategic measures. We might have to program things a little bit differently, more intentionally than you might have to do when you were younger, where it was much easier for you to be able to sustain muscle mass. And then we definitely want to be correcting thyroid function. As I mentioned earlier, your thyroid is extremely responsible for blood sugar and glucose metabolism. Our thyroid also is really important for regulating inflammation levels in the body, for supporting our cognitive function. We know that like low thyroid hormones can lead to more issues like depression happening, which you're already more susceptible to once you're postmenopausal because of the drop in estrogen, which also helps with mood and serotonin production. And so we want to make sure we're correcting thyroid function as early and as quickly as we can. Unfortunately, a lot of times the thyroid goes missed in menopause because a lot of low thyroid symptoms mirror menopause symptoms. So a lot of times you'll go to the doctor, you'll tell them you're having these symptoms, and they're like, oh, well, you're going through menopause, so these are natural symptoms to have, when you could actually be developing a thyroid condition. It is most common to see new conditions like thyroid diseases, autoimmunity develop anytime that there's a big hormonal transition. So that could be menopause, that could be pregnancy. So menopause would obviously be one of those situations. So I'd always recommend preventatively, checking your thyroid, not just TSH, but also T4, T3, thyroid antibodies, so that you can really make sure that your thyroid is staying in a healthy range, and then taking some measures to correct that thyroid function holistically, through all the measures we talk about in the Strength and Hormones podcast, because that is what's going to provide you a little bit more support in glucose metabolism. So remember, kind of as we talked about earlier, we talked about how like estrogen and thyroid hormones both impact your blood sugar and glucose metabolism. So it's not just we want to support our estrogen or we want to work with our low estrogen. We want to also support our thyroid, because even though you've gone through menopause, menopause is a sex hormone transition, right? It's not a thyroid hormone transition. We just often see the thyroid get impacted because of the change in sex hormones. But in theory, we should be able to naturally restore thyroid function much easier than it would be to restore like estrogen and progesterone. You can't really do that postmenopausally unless you replace those hormones, because the ovaries no longer are making them. So we have the ability to correct thyroid function. Let's do it, because it's only going to help with your glucose and your blood sugar control even more. And then we can work with building and sustaining lean muscle tissue, because again, the more muscle we have, the more of that metabolic weapon we have on board to help with blood sugar metabolism. So we've got a couple of different resources for you. I mentioned a few different podcast episodes that would be good follow-ups to this conversation if you have like questions in any of those areas. We also have our hormone testing packages. We have our blood sugar testing package, as well as our thyroid hormone testing package. A lot of these are not ran at the doctor. Your doctor generally is not going to test for fasting insulin. They're not going to test for free T3, reverse T3, thyroid antibodies, unless you're working with someone functionally. So we have those because we want you to have the access to those tests so that you can get that information if you need it. So we're going to include both of those in the show notes below so that you can look into that if you think that you need some clarity in those areas. I always recommend, getting them tested a couple times per year so that you can check in on how things are doing. And then with that information, then we can really understand, okay, how do we need to adjust your diet, your exercise, your supplementation to really maximize how the body is working. We see it done all the time. You are not doomed because you've gone through menopause. As I mentioned earlier, it's just that there's a different situation hormonally going on, and we have to understand, recognize that, and work with these natural shifts that are happening in the body. We'll see you guys next week for another episode. If you guys have any questions, you can always feel free to come message me over on Instagram at functional.fueling. I'll talk to you guys then.